Hello, everyone. My name is Keshav Patel, and I am a fourth year medical student. The title of this poster is Initial Presentation of RCC as Heart Failure Secondary to Tumor Thrombus Extension to the Right Atrium. So let's dive right into the introduction. Renal cell carcinoma accounts for 90% of renal malignancies, and at the time of diagnosis, 16% of RCC patients have metastatic disease. RCC can invade through the renal vein and into the inferior vena cava, with tumor thrombus formation reported in 5 to 15% of patients. From the IVC, the RCC can grow intravascularly and extend into the right atrium. RCC extension to the right side of the heart is a rare complication that occurs in approximately 1% of RCC patients. In patients with metastatic RCC, initial presentation can vary depending on the location of the metastasis. We present a rare case of RCC tumor thrombus extension into the right atrium, resulting in a 6.9 by 3.8 centimeter mass, leading to severe tricuspid valve functional stenosis and initial presentation of RCC as acute heart failure. So let's move on to the case. A 69-year-old woman with a past medical history of hypertension presented with fatigue and dyspnea on exertion. Her vital signs were unremarkable, and physical exam revealed jugular venous distension and faint bibasilar rales. EKG and troponin levels were both normal. CMP revealed an elevated creatinine of 1.5, and BNP was elevated at 1,243 picograms per milliliter. Chest X-ray revealed pulmonary vascular congestion and cardiomegaly consistent with heart failure. TEE revealed a dilated right atrium with a 6.9 by 3.8 centimeter echogenic solid mass occupying the entire right atrial space and impinging on the tricuspid valve, leading to functional stenosis. In images A through C of Figure 1, we can see the solid echogenic mass in the right atrium with different views. In image D of Figure 1, we can see the gradients across the tricuspid valve. CT was ordered to look for possible causes of this mass. Of note, CT without contrast was ordered because of the patient's elevated creatinine. CT revealed a large multilobulated 12.8 by 9.3 centimeter solid and cystic right-sided renal mass and enlargement of the renal vein suggestive of tumor thrombus. In Figure 2, the white arrow points towards the renal mass. The black arrow points towards the tumor thrombus extension into the renal vein and inferior vena cava. In Figure 3, the white arrow points towards the normal portion of the kidney, and the black arrow points towards the solid and cystic renal mass. Our patient was referred for oncological and surgical evaluation of RCC. Moving on to the discussion. Our patient presented with two uncommon findings: tumor thrombus extension leading to a 6.9 by 3.8 centimeter right atrial mass, and initial presentation of RCC as heart failure. The large right atrial mass caused severe functional tricuspid stenosis with a peak gradient of 13 millimeters of mercury. The RCC classic triad of flank pain, hematuria, and a palpable abdominal mass is only found in 6 to 10% of patients. Although initial presentation of RCC with heart failure is extremely rare, RCC extension to the right side of the heart occurs in 1% of RCC patients. Although initial presentation of RCC with cardiac symptoms is surprising, this case highlights the importance of maintaining a comprehensive differential diagnosis. The differential diagnosis for an atrial mass includes a myxoma, thrombus, vegetation, and primary or secondary neoplasm. Many other primary tumors, including kidney, liver, lung, and thyroid, can directly invade the atrium or by way of the vena cava. This report emphasizes the importance of further workup and imaging of atrial masses. Thank you for your time, and please let me know if you have any questions.